Thank you so much. Thank you for having me. And so today I wanted to discuss about acute and chronic kidney disease in dogs and cats. And so I finished my residency recently, less than 2 years ago. And so when I saw this topic, oh, sorry, something is not working on my screen. What's wrong? It seems like I can't change slides. That's interesting. I'm not too sure why.
You can try clicking on your PowerPoint slide. Sometimes the GoToMeeting sometimes takes it away. So if you click there, then you might be able to try to advance.
Yeah, the other reason is if you're using that laser pointer, it won't advance the slides. You have to change back to the
arrow. Let me check on that.
Or you have to do it with the page up, page down button. I think will advance them.
Okay, that's better. Thank you for that. So I was wondering then, what do we know about acute and chronic kidney disease? Because I remember that we've been talking about it, but being like a fresh diplomat, I couldn't remember any recent papers about that. And even in the textbook, when I double check everything, in a Tinger, there's one sentence to mention it, that it's active kidney disease that can exist with CKD. And when I went over the nephrology and neurology of small animals book, there were like 2 or 3 sentences to mention it. And so that basically in patients presenting for AKI, if the patient is having a poor body condition, then we could have a suspicion of acute and chronic kidney disease. Or that animals with CKD or acute and chronic kidney disease may have pale mucous membranes on presentation, or that a uremic crisis could occur in patients with CKD as a consequence of a superimposed acute renal failure or pre-renal or post-renal condition. And so then it will be the so-called acute and chronic uremic crisis. So in terms of papers, I found one from GVEC that was mentioning the use of continuous renal replacement therapy for treatment of dogs and cats with acute or acute and chronic renal failure. And so they mentioned the incidence of acute and chronic renal failure in their patients. So 0.56% in dogs and 1.74 in cats. And they concluded that continuous renal replacement therapy was a viable option to manage acute or acute and chronic renal failure in dogs and cats. But that's basically everything that I could find, so not a lot. So that's why I was very interested by those 2 papers about acute and chronic kidney disease in dogs and cats. And so before diving into those 2 papers, I felt that it may be good to go back to the basics with a few definitions. So chronic kidney disease, it's when we have functional or structural changes in one or both kidneys for more than 3 months. And acute kidney injury is defined as a sudden damage to the renal parenchyma, which may be accompanied by an abrupt decrease in GFR. So coming down to acute kidney injury, there is the grading system from the International Renal Interest Society. And so this grading system reflects a moment in the course of the disease. And so basically, we have 5 different grades. Grade 1 being patients that are non-azotemic, they may be oliguric, and they are fluid volume responsive. Grade 2 are going to be patients with mild azotemia. They may or may not be oliguric, and they are also usually fluid volume responsive. While grade 3, 4, and 5 have an increased severity of the azotemia and the functional renal failure. Accompanying this grading system, there is 2 subgrades. Animals are classified as being oliguric or non-oliguric, and as having a need of a requirement for a renal replacement therapy or not. So if we try to think about CKD and AKI in dogs and cats, here is just like a small summary with the prevalence, which is for CKD around 7% in dogs. In cats, it's more variable, but up to 20%. And for the prevalence in AKI, I only found it in that GVEC paper from 2008. So this was a referral center with renal replacement therapy. So those numbers may not reflect the real incidence of AKI in general. In terms of age, CKD tend to occur in older patients, while AKI can occur at any age. There's huge variation in the age, both in dogs and cats. In terms of progression, we know that CKD tend to be gradual. Sometimes it can be sequential. And sorry, there is a typo there. Those two should be changed. While AKI can be reversible, can lead to chronic kidney disease, or can be fatal in up to 50% of the cases. So in chronic kidney disease, there's been several risk factors that have been defined for the progression of the disease. And so in dogs, we recognize anemia, low body condition score, proteinuria, hypertension, hypoalbuminemia, and high-risk staging. In cats, we mainly bear in mind proteinuria and hyperphosphatemia. And here I just put a reminder about the risk factors, not for progression, but just for occurrence of acute kidney injury. And so definitely, dehydration and volume depletion, pre-existing renal disease, advanced age, electrolyte changes like hyponatremia, for example, nephrotoxic drugs combination, giving a combo of furosemide and gentamicin, for example, could definitely favor acute kidney injury. Reduced dietary protein intake in dogs, as well as shock, acidosis, and sepsis. So in terms of causes, chronic kidney disease can be associated with glomerular disease, infections, ischemia, nephrotoxicity, neoplasia, previous acute kidney injury, urinary obstruction, and frequently it is idiopathic. In cats, we encounter a number of similar causes. For AKI, for acute kidney injury, causes are going to be ischemia, infection, nephrotoxicity, inflammation, urinary obstruction, or tear. Those are going to be the main causes. So the aim of those 2 studies were to characterize the etiology, the clinical and laboratory findings, as well as the short and long-term prognosis of acute and chronic kidney disease in dogs and cats. So this was a descriptive retrospective studies over a 2-year period. So there was different inclusion and exclusion criteria. In terms of inclusion criteria, the patients had to have an acute onset of clinical signs compatible with acute kidney injury, so like anorexia, lethargy, or vomiting. They had to have azotemia, defined as a serum creatinine concentration above 1.6 milligram per deciliter. And they needed one or more of the following criteria. So a previous persistently increased serum creatinine concentration, with a concurrent increase, so more than 25% in dogs and more than 20% in cats, above the previously documented baseline. And they had to have also, so only for cats, this was only in the cat study, a previous diagnosis of CKD with concurrent presence of urinary markers consistent with acute injury, so like glucosuria or cylindruria. And of course, they needed ultrasound changes compatible with CKD, so like increased renal echogenicity or decreased renal corticomedullary differentiation or decreased kidney size, etc. Animals were excluded if they were euthanized within the first 48 hours after admission. So survivors in those studies were defined as animals alive at discharge from the hospital, and non-survivors were the patients that died or were euthanized. And so the authors created categorization for the etiologies, and so they somewhat differ in between dogs and cats, but all in all, they are quite similar. So presumptive inflammation was a category of etiology for dogs mainly, with pancreatitis and glomerulopathies. Ischemia was also another big category. And in dogs, this ischemia could be because of administration of furosemide, NSAIDs, severe dehydration, or very recent general anesthesia. And in cats, the reasons for ischemia were the same than dogs, except that there was also trauma, with particularly cats with high-rise syndrome and hit by car. In cats, there was ureteral obstruction as a big category. Pyelonephritis was another category. And then there was a category named other renal, which were less frequent causes, possible causes of acute kidney injuries in those patients. And so in dogs, we could see unilateral ureteral obstruction, hypercalcemia, cardiorenal syndrome. Or cats, it was more PLN. We had also the cardiorenal syndrome, or we could see infected renal cortical cyst and pancreatitis. So pancreatitis in cats figured under other renal, whereas in dogs, it was just under the presumptive inflammation. And of course, we had the category idiopathic. So a collection of samples and laboratory methods were quite classic. Most of the patients had CBC, biochemistry, and urinalysis, with urine samples being collected by cystocentesis. They did urinalysis with a dipstick chemistry and sediment cytology, either with the SediView or the manual microscopy. Some patients had bacterial culture. There was also a measure of USG. And then there's few definitions of pyuria and hematuria, bacteriuria and proteinuria that are quite classic. And then UPCR was only measured in dogs with severe proteinuria when the urine dipstick results was more than 4+, or when there was a clinical concern that glomerular disease was inciting cause for the acute on chronic kidney disease. And interestingly, there's no mention of UPCR in the cat study. So statistics, everybody's favorite part. They were quite, fine to me, those tests. So they used the Shapiro-Wilk test to assess for normality. And so since the variables were not normal, they used the Mann-Whitney test for continuous variables and the chi-square or the Fisher's exact test for qualitative variable. And then they did a univariable analysis to assess the association of the outcome with clinical signs, clinical pathologic findings. And so if results were significant, then they used the multivariable logistic regression analysis. And then they use the Kaplan-Meier survival curves with log rank test to compare the median survival time of the dogs and the cats, categorized based on serum creatinine concentration at presentation for the dogs, or categorized based on iris acute kidney injury grades in cats. And so they compared that to the presumptive cause of AKI in dogs and serum creatinine concentration categories at discharge. And in cats, they did a little bit more statistics, particularly for the multivariable logistic regression analysis, where they assessed the goodness of fit of the significantly associated variables, and they performed an analysis to determine the sensitivity and the specificity of the statistically significant analysis, statistically significant parameters after the multivariable analysis. And they also performed a Cox regression and time-dependent covariates, which I'm not very familiar with, so I won't expand too much on that. So moving on to the results. And so first, results regarding signalment and survival. So for the dog study, they found in the records 139 dogs, and for cats, 159 dogs. A number of them were excluded, either because of missing data or because they were euthanized within the 48 hours of hospitalization. So in the end, in both studies, we had 100 animals included. In terms of sex, male and female were quite similar in proportion. In the cat study, we can notice that there were many non-spayed animals, females particularly. And then in terms of breed, in dogs, we had mainly mixed breeds, while in cats, it was mainly domestic shorthair, while there was a fair number of Persian cats. In terms of survival, in dogs, 65% survived, while in cats it was 58%. It sounds like amongst the non-survivors, cats were less frequently euthanized compared to dogs, and they were dying a little bit more on their own, 31% in cats versus 20% in dogs. And so in dogs, there was no body weight or age difference between the survivors and the non-survivors, while in cats, age made a difference since non-survivors were significantly older. However, when we look at the numbers, the median and the range were quite close, and so those were in months. So I had to change them in years so that it's more obvious to me. And so it's 11.5 versus 10-year-old. So I mean, it's statistically significant. Clinically, I'm not as convinced. Body weight didn't make a difference between the survivor and the non-survivor. In terms of clinical presentation, it was quite similar in dogs and cats. The main clinical signs were non-specific. So we had anorexia, lethargy, weight loss, and vomiting. In dogs, diarrhea was more prominent compared to cats. And then there was a myriad of additional clinical signs. Urinary incontinence came up in both dogs and cats. And there was other like neurological signs in dogs, like circling and seizures. So I was kind of curious to know what was the reason behind those signs in those patients. Other question that I had when I looked, at those clinical signs is that I didn't see anything regarding potential oliguria or polyuria or polydipsia, or oral ulcers. So I found this interesting. And also in dogs, there is the mention of pain. And then I was questioning if this was maybe abdominal pain or pain, back pain, or pain somewhere else. But otherwise, in terms of clinical signs, the proportion of those clinical signs did not differ between the survivors and the non-survivors. The respiratory rate at presentation in dogs was lower in the non-survivors, while in cats, it was the rectal temperature that was lower in the non-survivors. Otherwise, in dogs, there was no difference in heart rate and temperature between the two different outcomes. And in cats, there was no difference in the heart rate and respiratory rate between the two outcomes. So in terms of causes and concurrent diseases, in dogs and cats, the main cause of acute and chronic kidney disease was idiopathic, which is not very surprising, and even more in cats than dogs. In dogs, the next more prominent category was inflammatory, followed by ischemia and pyelonephritis. In cats, ureteral obstruction was a frequent cause also, as well as ischemia and pyelonephritis. So the main categories in dogs and cats were quite similar, apart from the ureteral obstruction in cats. And then there was like some evidence of cardiorenal syndrome in both dogs and cats, hypercalcemia in a dog, protein-losing nephropathy in 2 cats, and polycystic kidney disease with 1 infected cyst in 1 cat. So the proportion of those etiologies between the survivors and the non-survivors did not change, neither in dogs or cats. In terms of median hospitalization period, it was very similar in dogs and cats, about 5 days. And this hospitalization time was shorter in the non-survivors. In terms of hospitalization period among the etiology groups, there was no difference neither in dogs or cats. And so if we move on to the concurrent diseases, pancreatitis was a big concurrent disease, both in dogs and cats. And this didn't impact the outcome. There was no difference in the percentage of dogs or cats with pancreatitis between the survivors and the non-survivors. Additional concurrent diseases were heart disease, oral diseases, keratoconjunctivitis sicca, and polycystic kidney disease. So in terms of clinico-pathologic findings, anemia was quite common, both in dogs and cats. Interestingly, I found that hyperbilirubinemia was quite prevalent in cats. And I don't know if you noticed, but in the previous slides about the clinical signs, there was only 1 icteric cat reported. So when I saw that hyperbilirubinemia was quite prevalent, I was surprised. And so actually looking at the numbers, we can see that the median for both groups, survivors and non-survivors, is at the high end of the upper range. So I feel like probably this hyperbilirubinemia is likely marginal for most of the cats. And particularly when we see that on the urinalysis, there's only 3 cats with bilirubinuria. So frequent change on blood work may be of small magnitude. So regarding the univariable analysis, the red blood cell count was lower in the non-survivor in dogs. And they found out that the creatinine, urea, phosphorus, and creatinine kinase were significantly higher in the non-survivors. And so they also determined that the creatinine concentration significantly decreased in the survivors between presentation and discharge, and that the creatinine concentration was significantly lower in the survivors than in the non-survivors, when the non-survivors were at death or euthanasia, which, I mean, makes sense. The serum chloride was also significantly lower in the non-survivors, while for the venous blood pH, there was no difference. So if we focus on cats, only serum creatinine, urea, and phosphorus were significantly higher in the non-survivors. And so the creatinine changes were quite similar than the one observed in dogs. It was decreasing at discharge for the survivors, and it was significantly lower for the survivors compared to the non-survivors at death or euthanasia. The venous blood pH was significantly lower in the non-survivors, so this made a difference in cats, to the contrary of dogs. The DGGR lipase activity was measured in both dogs and cats to assess pancreatitis, and so it was significantly higher in the non-survivors in dogs. And so when they moved on to the multivariate analysis, the respiratory rate, creatine kinase activity, and serum creatinine were the one to be significantly associated with outcome, while in cats, phosphorus only was associated with outcome. And so a cutoff value of 16.7 milligram per deciliter corresponded to a sensitivity of 53% and a specificity of 77%. So urinalysis, there was the median USG was low, which was expected. So we had lack of concentrating ability. Interestingly, some animals were able to concentrate. The range was up to 1040. So in the discussion, the authors mentioned that some animals with CKD maintain urine concentrating ability in the early stage of the disease. So that would explain this finding. In terms of urinalysis abnormalities, in both species, proteinuria, hematuria, and bacteriuria were the more prominent changes. And I have to say, I was a bit surprised by that because I was like with an acute, kidney injury, I was expecting like maybe more signs of tubulopathy, like more casts or more glucosuria, which didn't appear to be like very frequent. And so I went back to a study from Dr. Vaden in 1997, who was reviewing acute kidney injury in dogs. And so in that study, only 6 dogs out of 89 had more than 5 casts per low power field. And in that study, also glucosuria was present in 19 out of 84 dogs. So a bit more than in the present study, but not as frequent as I was thinking. So. In terms of urine culture results, a quarter to a third of the patients were positive, with E. coli being the most frequent organism isolated in both dogs and cats. So moving on to the follow-up and long-term survival. So for the dogs, the median survival time was 105 days, with 57 being alive at 6 months and 30% alive at 12 months. 3 dogs were only alive at 24 months. In cats, the median survival time was shorter, 66 days. More of them were alive at 6 months, 81% compared to dogs, but only 8% were alive at 12 months. And then I couldn't get my head around this number because it says that 11% or 6 cats were alive at 24 months, which is more than the one at 12 months. So I'm not sure if there is a typo or if it's just I reread this sentence a few times and maybe I just don't understand it. There's maybe something I miss there. So if we focus on the survival by acute kidney injury iris stage at presentation, and it's not cats only, it's for both dogs and cats, we noticed that there was a significant decrease in survival with increased iris acute kidney injury grade at presentation. And in cats particularly, they could make a difference between grade 2 and 3 versus grade 4 and 5. And we can definitely see that the median survival time was quite different, 29 versus 233 days. So focusing on the survival by serum creatinine concentration at discharge. So the iris stage was at presentation, right? So at presentation, we can have an idea already of things, but serum creatinine at discharge was helpful only for cats. It was significantly associated with long-term survival in cats only. In dogs, there was no association between the serum creatinine concentration, neither at presentation or at discharge, and the long-term survival. And so this is reflected by this graph. We can see that there was no difference in the median survival time among the different stages. There's quite a bit of overlap in dogs. Whereas in cats, we can see that the stage 1 and 2 can survive longer. And actually, there was a fair number of cats that were still alive at the time of writing, while for stage 3 and 4, the curves are tanking. So survival by etiology didn't make a difference in dogs. In cats, however, the group with ureteral obstruction survived longer compared to the other etiologies. So that definitely has an impact. So moving on to the discussion, now that we reviewed all the results, definitely, you know, with what we have, we can say that clinical presentation was similar to acute kidney injury in dogs and cats with acute and chronic kidney disease. Therefore, the differentiation between the two conditions can be quite challenging because those clinical signs are fairly non-specific. And so having the history of the patient, a recent creatinine concentration, and ultrasonographic changes can be helpful to differentiate the two. Also, weight loss can be a marker of chronic kidney disease. However, it was present only in 16% of the dogs. So it may not be as helpful as we'd like. In cats, it's a bit more frequent, 39%. So definitely maybe a better tool, generally speaking. There's few cats particularities that were highlighted in the discussion. It's that there was a relatively high proportion of non-spayed females, even for Israel. So it sounds like Israel is a little bit like Europe. People tend to spay less their animals. But the others say that it's unclear why they had so many non-spayed female and that it's unlikely to influence the results of this study. And also the cats were quite younger compared to previous reports. So it's also possible, you know, that nowadays there is an earlier diagnosis of chronic kidney disease. And since ureteral obstruction was a frequent cause and that these tend to occur at a younger age, this could explain this discrepancy. Discussing about the presumptive causes of acute and chronic kidney disease. So when it's idiopathic, and it's quite frequently the case in both dogs and cats, it doesn't carry a negative prognostic indication. Also, when the causes are identified, most of the time they are pretty similar to the one of acute kidney injury. In dogs, we recognize the inflammatory conditions, the pyelonephritis, and the ischemia. In cats, we recognize ureteral obstruction, pyelonephritis, and ischemia. The main difference compared to acute kidney injury is that we didn't have nephrotoxicity. So is it because, for example, in dogs, those dogs tend to be older because they have some CKD and they are less prone to go into foreign objects? Or is it because the owners are more aware of the possible clinical signs or risk of developing kidney disease? This is unknown. And in dogs, there was a little focus on pancreatitis because it was considered an inflammatory cause in dogs when there was no other obvious causes of acute kidney injury. So definitely pancreatitis can be a cause of acute kidney injury because of the inflammatory cytokines that are released with the pancreatic inflammation. This can lead to decreased renal perfusion and apoptosis of the renal tubular cells. Pancreatitis might also perpetuate kidney injury, so definitely it can play a role anyway. For the cat, there was a small focus on the ureteral obstruction because it's quite frequent as a cause of both acute kidney injury and acute and chronic kidney disease in cats. And it tends to be associated with quite a good outcome in those patients. And so this is probably because it can be treated. This reflects that maybe owners should be encouraged to pursue treatment even if their cats has concurrent CKD. So then there was a discussion about the outcome predictors. And so amongst the univariable analysis, one factor that was associated with outcome was creatinine kinase in dogs. And so in sick cats and humans, creatinine kinase activity has been associated with disease severity. And definitely, you know, we can understand that physiologically hypovolemia and shock can lead to rhabdomyolysis and contribute to some degree of mortality. And or that myocardial injury might have a role in some of the dogs of this study. So this would make sense, but those would be the explanations for this factor to be associated with outcome, I should say. And also in dogs, lower hematocrit and red blood cell count were hematocrit and red blood cell count were lower in non-survivors. And so this could reflect a more advanced chronic kidney disease before the acute injury, or maybe some degree of GI bleeding that could be associated with decreased GI perfusion or maybe hypergastrinemia. In cats, they focused mainly the discussion on the phosphorus concentration, which was the only significant outcome predictor. And so this physiologically makes sense because phosphorus is fully filtered by the glomeruli, so its concentration is going to be highly affected by the GFR. And we know that in CKD, hyperphosphatemia is associated with the progression rate of the disease. So why would this be a factor in acute and chronic kidney disease? Well, I mean, hyperphosphatemia can come from the chronic kidney disease in itself. It can be associated with the acute kidney damage, or it can be from both. Interestingly, it's not a negative prognostic factor with acute kidney injury. But so this hyperphosphatemia may reflect a more advanced CKD before the occurrence of acute and chronic kidney injury. So measuring PTH and fibroblast growth factor may help to investigate this further. And so then there was a small discussion about pancreatitis and acute and chronic kidney disease. With acute kidney injury, pancreatitis is quite prevalent in dogs, 62%. I didn't find the incidence of pancreatitis in cats, with acute kidney injury. So maybe I missed it, but I don't think it's been described. So pancreatitis with acute and chronic kidney disease was quite prevalent too, with 34% of the dogs having pancreatitis versus 54% of cats. And so the presence of pancreatitis didn't make a difference in terms of outcome, except that for dogs, there is a DGGR lipase activity that was higher in the non-survival. So maybe this reflects that those dogs may have had more severe pancreatitis. That would explain then the poor outcome. And of course, the authors mentioned that pancreatitis, it's unclear, we can never say if it's a cause or consequence of acute kidney injury. So in terms of discussion regarding the outcome and survival, the median hospitalization time was quite similar in dogs and cats, and it's comparable to acute kidney injury cases. The fact that the hospitalization duration in non-survival cats was shorter fits with the fact that those guys were dying earlier or were euthanized, so this made sense. And the fact that hospitalization duration was significantly longer for the survivors is consistent with previous studies regarding acute kidney injury, and will allow clinicians then to guide owners' expectation regarding that duration. They will know better where to go. So interestingly, the mortality rate of animals with acute and chronic kidney disease during hospitalization was lower in dogs and cats compared to the mortality rate of acute kidney injury. And so this was quite unexpected because we would think that the kidneys were initially damaged, and on top of that, they would have additional injuries. So we would expect that maybe they would do less well compared to animals with only acute kidney injury. And so in the discussion, they mentioned that this may be due to the underlying cause and the reversibility of the injury. Because pyelonephritis can be treated, for example, versus like patients with nephrotoxicity may not do as well. And nephrotoxicity is more seen with acute kidney injury. Also, the fact that owners of patients with chronic kidney disease are aware that their animal has already like some degree of disease, maybe they're more sensitive to any subtle changes in the clinical setting. So maybe they will seek early medical intervention, which may then also explain a better outcome. The short-term prognosis of patients with acute and chronic kidney disease is fair, while the long-term prognosis is guarded. And it's actually poorer in dogs compared to acute kidney injury. The survival rate at 1 year is lower with acute and chronic kidney disease. And so in the discussion, they mentioned, that in patients with chronic kidney disease, the long-term prognosis depends on the disease stage. But that with acute and chronic kidney disease, the median survival time, which vary with creatinine as discharge, at discharge time, but there's no significant difference amongst those stages. So the fact that the kidney are already damaged without any reversible injury may explain, these short-term survival. And the creatinine at discharge is associated with long-term survival only in cats. So there were a few limitations to those studies, mainly the retrospective nature. The heterogeneity of the population, because the veterinary center was a first opinion, but also a secondary and tertiary referral center, which, I mean, in my opinion, is more strength than a weakness. It's more reflective of the general population. There was limitation in the classification of the cause of acute and chronic kidney disease because those were mainly based on the known causes of acute kidney injury. So maybe some causes could have been missed, other causes. The effect of the high-risk CKD stage before the acute injury could not be assessed. The treatment was not standardized, so it could have impacted the outcome. And of course, the outcome could have also been influenced by owners' finances or emotional state, as well as clinician decision too. So the take-home message of those papers, the common presumptive causes of acute and chronic kidney disease in dogs are going to be mainly inflammation, pyelonephritis, and ischemia, while in cats it's going to be ureteral obstruction, pyelonephritis, and ischemia. The short-term outcome is fair. The long-term prognosis is guarded. The prognostic factors for survival to discharge in dogs are going to be respiratory rate, serum creatinine concentration, and creatinine kinase activity, while in cats, it's going to be serum phosphorus. And the prognostic factors for long-term survival have not been identified in dogs, and in cats, it's going to be the serum creatinine concentration. So I was curious to know how frequently you see acute and chronic kidney disease, because I felt that over a 2-year period, they recruited quite a fair number of cases, actually.
I think one common scenario that we find ourselves in is maybe diagnosing a patient with acute kidney injury, but then as we're going through the diagnostics, we are finding out that there was probably some evidence of chronic disease that had been missed, that looking back through the history, there's been weight loss that has been noted, but wasn't done anything by the owner, or when we do finally image their kidneys, they're more consistent with chronic kidney disease than acute kidney injury. So we do see a lot of animals, I think, coming in with their acute on chronic, and we're kind of diagnosing them because of the AKI component of it. And that's when we often find that they do have CKD. And certainly there are a lot of our dialysis patients that we start dialyzing them for the acute component, and we find out that there is a decent amount of chronic disease that's left behind that might prevent them from recovering back to normal kidney value. So I think we find that a lot more commonly during the process of evaluating for an acute kidney injury, that there's some chronic disease that's left behind.
Yeah, that makes total sense. And then so I could see that in the material and method, they used SediVue to do their urine cytology. And so personally, I've never used it. So I was wondering if some of you are using it, and if so, if you like it, because I have really zero experience with the SediVue.
Yeah, and just also, I'm paying attention to some of the people on the chat. They're also commenting that, they're seeing a lot of patients similarly coming in with acute on chronic disease, both from the emergency room perspective, seeing a lot of those, and then, when the more kidney cases you're seeing, the more commonly that those are going to be observed. So I think it does seem to be a more common condition that we observe. I do distinctly remember when I was in vet school hearing when I was in clinics the term acute on chronic kidney disease, and never having heard it during the actual lectures. Now I could have fallen asleep through those lectures. That's certainly a possibility, but it was a new term that I was just unaware of. But it felt like we were seeing a lot of them in clinics, and I think it's continued from there personally. since I've stolen the microphone, I'll certainly say that we have a SediVue here and we use it. I like it a lot because we get the images so that we can look at the urinalysis. It is it's not a perfect machine, but it's gotten dramatically better over the last 2 years. Just the updates that they've done to it, it's really improving. The more tests that collectively the SediVue does, the better it gets, and it's a really nice machine to be able to identify if you have pyuria and hematuria, especially if you have a busy practice that you're unable to make and prepare your own slides to look at. So we use it here, but we also make air-dried slides that we stain on all of our urinalyses that we look at ourselves as well too. So we do it in combination with the SediVue.
I'd like to also point out that, first of all, a very nice presentation. Really, you certainly did an extremely thorough, incredible job of this report. But one of the things that kind of differed was their definition of acute on chronic versus the IRIS grading system. And so, a 25% increase in creatinine to identify the acute component would be different than the IRIS grading guidelines, where that would suggest that a 0.3 change in creatinine would define an AKI on whatever pre-existing acute documentation of the patient's kidney disease would be. So maybe the prevalence of acute on chronic would even go up if a more stricter definition was used. And I would hope that going forward that we would all kind of adopt a uniform definition of what is going to be acute injury.
Yeah, and I was also very surprised. I was intrigued by the fact that they used 25% in dogs and 20% in cats. And I had a brief look. I didn't look for it for ages, but I didn't find a reason why they would use 25 in dogs versus 20 in cats. So, I mean, if you know that, I'd love to know why.
I can comment on that. This is Gilad. I'm one of the co-authors. And yeah, I have to admit that we don't have a good definition of acute and chronic. And it was very difficult for us to use the IRIS definition for acute kidney injury. Obviously, the IRIS definition would be applied to any animals with acute or acute and chronic. But the problem is that these animals with chronic kidney disease, sometimes you have a baseline creatinine concentration of these animals, but that was like 6 months ago. And so if you had an animal with a creatinine concentration of 4 milligram per deciliter, and now it presents with acute signs of whatever, acute clinical signs, and the creatinine is 4.3 or 4.4, do you really know that this is representing a real increase or a real acute increase within 48 hours? Per the IRIS definition of serum creatinine concentration, or maybe the reason for 4.3 now is just a slow progression of the disease, and it used to be 4 and now it's 4.3. So it's really difficult in these patients in which you do not have a baseline creatinine concentration just prior to the acute insult to use such a strict criteria. So we elected to use 25%. In cats, we saw that the cutoff, there's NAS cutoff in 20%, but these are really numbers that we cannot defend with solid evidence, because we just wanted to say we just want to make sure that there was acute and chronic event in these patients. So as much as we would like to use the IRIS criteria for that, this is almost impossible because you don't have serum creatinine concentration just before the acute deterioration. And so this is why we have to use three criteria. And I would admit that sometimes it's really difficult. We had to exclude cases in which we were not sure whether there's acute or acute on chronic, or whether the acute presentation of clinical signs can really be attributed to acute deterioration of the kidney disease. So if you have a dog with chronic kidney disease and based on creatinine concentration of like 2 a year ago, and now it presents with 2.5 and acute onset of clinical signs and you have concurrent pancreatitis, it's more likely that the pancreatitis is responsible for the clinical signs and not acute on chronic, for example. So these criteria will have to be defined. I think this is something that we as a profession will have to address in the future, maybe more accurately and uniformly. But I would agree that these are not set in stone and prone to changes in the future.
Yeah, I suspected, Gilad, very much that was the reason that you had to use sort of a blanket cutoff. I just wanted to make hopefully the point that as a group, you know, that we start adopting some definitions for the problems that we're trying to sort out.
Yeah.
Thank you for this. That's great to have your opinion. And speaking of pancreatitis, actually, I was at some point also questioning the use of the GGR lipase to diagnose pancreatitis in patients with kidney disease, because we know that kidney disease, renal failure, I mean, can interfere with lipase concentration, can increase it since lipase is excreted by the kidneys. And so I found that recent study from 2020 from Dr. Dunn. And so in that study, they used like 49 cats. They had 3 different groups. A group of sick cats with kidney disease, and those sick cats didn't have pancreatitis. They were sick for another reason. There was a group of sick cats without kidney disease, and there was a third group of healthy cats. And basically, in this study, they found that the cats with kidney disease had a significantly higher serum DGGR lipase concentration, but that this difference was minimal and not clinically relevant. So how much, you know, is this going to make a change in patients with pancreatitis? I don't know, but at least I felt that it was good to know that. So and then I was curious to know, I mean, in your patient, like with kidney disease, like what do you use to diagnose like your pancreatitis? Do you go with a DGGR lipase, or do you stick to the spec FPL? Yeah.
I would say for us, we would use the FPL more commonly just because it's our more readily available test that we have. So that would be the one that we would turn to more often. We don't routinely run it unless we have some decent suspicion of pancreatitis causing the acute or acute on chronic disease. I know of other institutions that might run either some type of PLI or some type of pancreatitis testing on all of their AKI patients or dialysis patients to maybe understand if they might have a lesser ability to tolerate fat, things like that for nutrition, which maybe not the right application of that test if we're trying to diagnose pancreatitis. But yeah, I would say that we're usually using the FPL or the CPLI as the test that we use most of the time in my hospital.
We do use the DGGR lipase routinely just because it has been demonstrated to be comparable to the PLI test, CPLI and FPLI test, and it's so much cheaper for us to run that. So we run that as part of the biochemistry analysis rather than just using a different test. So it just more comfortable for us using this test, and that's the main reason. And I would agree that there's some limitations in animals with decreased kidney function, but as you presented in this study, when you look at these differences between animals with the CKD and animals without CKD, actually the difference in this specific study was very, very small. And as you had suggested, probably clinically not important. There's another study that was led by Stanley Marks, I think, in UC Davis, looking at animals with acute kidney injury and the use of CPLI in dogs. And again, no differences were found. And so although there is probably a reduction in lipase elimination, this does not seem to be that clinically important in those animals, preventing the use of DDGR lipase or FPL in cats with pancreatitis or suspected pancreatitis. So in other words, the fact that you have kidney disease should not limit the use of these tests. We do not run that routinely, but when we have clinical suspicion, we do, especially because this is relatively cost effective for us to do that. This is almost like another biochemistry parameter to run, and so we do it quite often.
Thank you. The cost difference makes sense, and yeah, thank you for your insights. So, and that's all the things I wanted to bring up today. I don't know if anyone has any questions or comments, or if there's even time left for this.
Julia, I really want to thank you. That presentation was really fantastic, very thorough, really excellent review and discussion of the two movies. That was really good. So thank you so much for doing that. And certainly thank you to the authors as well for doing that research, which was well needed. I think that was a great session overall.
I would like to comment a point in this work, in this paper. I think you all need to be to have a I cannot say. I think that in this presentation, we see a mixture of many causes, and this can do something wrong with the statistics. In my clinic, I don't consider urethral obstruction in cats or dogs as an acute kidney disease. And so I would like to propose that you think about, all of you, to have a better definition, including acute on chronic kidney disease. And to finalize, I appreciate very much the presentation. It was a good job.
Thank you very much. Thank you for your comment.
All right, I'll go ahead and stop the recording.